Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm joined by our deputy editor Nick Bostock to talk about some of the latest news affecting general practice. Coming up, we're talking about falling numbers of GP partners and what this could mean for the future of general practice. We're looking at what went on at last week's UK LMCs conference, where the BMA launched a new report highlighting the value of a GP, and there were debates on the employer national insurance increase and GP unemployment. And we're discussing the latest on plans to cut back ICBs after an NHS England blueprint suggested this could mean some big changes for primary care. Our good news story this week is about a pilot in general practice in Manchester that's aiming to cut falls among older patients. That's all to come on this episode of Talking General Practice. So first up, Nick, let's talk about GP partners. You've been wading through all the data on GP partners. What have you found?
So we've talked loads on the podcast and on the website about the fact that numbers of GP partners are falling, and the fact that they've been falling quite rapidly over at least the past decade. The latest figures we have are for March 2025, so up to the end of the last financial year. And the numbers from that set of stats show that there are around 6,000 fewer GP partners now than there were roughly a decade ago, which is the furthest back that NHS England's figures go. So full-time equivalent GP partners are down by about 28% compared with just under a decade ago. But really, that's the part we already know about. What I think is more interesting and worrying about the latest figures is that in each of the past 3 financial years, the number of partners lost to general practice has increased. So about 350 partners were lost in 2022-23, about 450 the next year, and then just under 550 in 2024-25. So these figures show that the decline in GP partner numbers is actually accelerating. And rising numbers of GP partners leaving each year from a total that's smaller each year means the rate of change is accelerating quite quickly too. So general practice lost about 2.1% of partners in 21-22, but 3.4% of partners last year. Ultimately, these numbers reflect the extent to which the clock is ticking for the profession's leaders and the government to step in and make sure that there are enough GPs in partnership roles to keep general practice going. One thing I think is worth pointing out here is that the figures also seem to show the impact of an incentive scheme that ran for a couple of years under the last government to try and boost partner numbers. In 2020-21 and then 21-22, the fall in partner numbers really slowed down. And that reflects the fact that the new to partnership scheme, which offered golden hello payments and sort of support for training, brought about 2,800 GPs into partnership roles for the first time around that period. The BMA has actually called for that initiative to be revived. And there's evidence here in these figures that it clearly had an impact.
Yeah, that's really interesting, isn't it? And it's perhaps not surprising that if you incentivise people to become partners, they might be more likely to consider it. And then actually, maybe when people get into those roles, they're potentially more likely to stay in them. We talked about falling numbers of partners on the podcast before, as you said there. I mean, most recently, we talked about it when we discussed that Health Foundation report, which called for the government to actively look at developing alternatives to the partnership model. That paper also highlighted the fact that partners are also getting older on average. So there's a risk that many of them will retire soon. Is this fall in partner numbers an existential threat to the partnership model, do you think?
It's a good question. One of the ways partners are lost to general practice is when practices close or merge. And just as the total number of GP partners has been dropping rapidly over the past decade or so, the total number of GP practices in England has also been falling. I mentioned that the number of full-time equivalent GP partners has dropped by about 28% over the past 9 years. Over the same period, the number of GP practices in England has gone down by about 19%. So partners are actually disappearing faster than practices. And what that means is that the number of full-time equivalent GP partners per practice has dropped from an average of about 2.8 in 2016 to about 2.5 now. If you add in the fact that the list size of an average practice has gone up from about 7,500 to more than 10,000 over that period, fewer practices, more patients, partners are each responsible for a lot more patients, and that points to more strain. So you could argue that's a risk to the partnership model if those remaining partners are more likely to burn out because of the pressure that they're under from those larger practices with smaller numbers of partners alongside them. Another way of looking at this, though, is if you look at the headcount numbers of GP partners per practice. And if you look at that, the decline's actually a bit less steep. It's dropped from about 3.1 to 2.9 headcount partners per practice. Again, obviously, those partners are running larger practices on average than their counterparts a decade ago, but it still means there are about 3 partners per practice like there were 10 years ago. I spoke to a lawyer from a firm called DR Solicitors who do a lot of work with general practice, and they said these numbers are probably more important from the point of view of business risk, these headcount figures, rather than the full-time equivalent ones. And that's because headcount partners haven't changed dramatically, and that means that neither has the risk of partners being left as what's called last man standing, the sort of sole remaining partner at a practice, stuck with all the risk and cost of the business. Another point they make is that the headcount partners per practice figures, or at least the ones that you get by dividing NHS England's sort of national headcount figures on the GP workforce by the number of practices, might not really be realistic because often partnerships can hold more than one practice contract. So the true figure for partners per practice may be higher potentially. So meaning a bit more resilience in those contracts than the basic figures suggest. Ultimately, though, however many partners there are in practices, we heard from the BMA this week that even after increases to GP contract funding over the past couple of years, they think that large numbers of practices are on the verge of collapse. And as I said, when practices close, partners go with them. So the real risk to partnerships perhaps is from the underfunding of general practice. And that's what GP leaders hope can change with the big new contract they want over the next couple of years.
Yeah, definitely. It is interesting. The general consensus is that the partnerships are in decline. I mean, we've got an opinion piece on the website this week from Dr. Hugh Miles, who's a GP partner, questioning whether that is actually the case. He makes the point that the proportion of practices that are run by partnerships has remained fairly consistent over the years. And what he suggests is perhaps the partnership is evolving and that there are now fewer partners running practices. That piece was very much written in response to that Health Foundation report that the government should look at other models to prepare for the collapse of partnerships. But Dr. Miles' argument is that we need to make sure partnerships are fit for the future rather than looking at any alternative models. And obviously funding is a really important part of that. The other important part is ensuring that GP partners have the skills they need to effectively run a practice, particularly around clinical leadership. And he argues that there needs to be a clear strategy to make sure that partners have those skills. I mean, I would recommend listeners read that piece if you can. You can find it on our website and we'll put a link to it in the notes for this episode, along with a link to Nick's analysis of the partner numbers. Nick, you wrote another story about sort of on the same topic at the end of last month that also showed the value of GP partners. This was based on a report by the Institute for Government think tank, which called on the government to take rapid action, actually, to tackle factors driving this decline in partner numbers. That report really highlighted some of the value that GP partners bring, didn't it? What actually did it say?
Yeah, so this was a report looking at how various different factors to do with practice relate to patient satisfaction. And what it found was that more GPs per patient, a higher proportion of appointments delivered face-to-face, and smaller practice list sizes were all linked to higher patient satisfaction. And in fact, to higher scores on the QOF, the performance-rated pay framework for general practice. But when it came to that link between more GPs per patient and higher patient satisfaction, they found that the link was even stronger for partners. So one extra GP partner in a practice was associated with a 1.4 percentage point increase in the proportion of patients who rate their practice good overall in that national patient survey. An extra salaried GP was associated with a 0.9 percentage point rise in satisfaction on average. An extra GP trainee linked to a 0.3 percentage point increase in satisfaction. So that link is significantly stronger when it comes to partners per patient. What the report pointed out is that at a time when patient satisfaction has slumped in the past few years, GPs per patient have been dropping and partners per patient have actually been dropping faster still. So there's perhaps a correlation between those two things. So this is another bit of evidence making the case for GP partnerships, but also for more GPs as a whole and for a move away ultimately from increasing numbers of appointments in general practice with staff who are not GPs.
You've touched on this earlier, didn't you? But the BMA and the government in England are now at the start of this process of developing a new GP contract. When we talk about partnerships, we're also talking about the independent contractor status. And the BMA will obviously have preserving that independent contractor status at the heart of its approach to negotiations. And hopefully, I think what it will be aiming for is to create a contract that will potentially help reinvigorate the partnership model. So we'll have to see what comes out of those discussions over the coming months and years as we head towards that new contract. Before we move on, just to let you know that MIMS Learning Live is returning to London on Friday the 13th of June, and this year it's heading to a brand new venue, the ILEC Conference Centre in Earls Court. Brought to you by our colleagues on MIMS Learning, this is an event you won't want to miss. It's your chance to boost your clinical know-how, connect with peers from across the UK and gain fresh insights that can make a real difference in your patients' lives. Spots will go fast, so head to mimslearninglive.com/London and get your ticket today. So last week was the UK LMCs conference, which took place in Glasgow. Nick, Dr. Katie Bramall-Stainer was on the podcast recently. She's the chair of the BMA GP committee in England. And in that interview, she mentioned a new paper the BMA was putting together, which would set out the value of a GP. She actually unveiled that at last week's conference. What does the paper say and what did Dr. Bramall-Stainer have to say about it?
So this report's called The Value of a GP. And Dr. Bramall-Stainer described it as a document that makes the indisputable, unarguable economic case for general practice loudly and clearly. The BMA GP committee leadership has talked a lot about the importance of persuading the Treasury that investing in general practice is essential, basically getting into the conversation within government as it pulls together its comprehensive spending review, because that's what's going to set the funding roadmap for the rest of this Parliament. In terms of what's at stake, even after GP contract uplifts for 2024-25 and 2025-26 that are well above anything the profession had seen in recent years, the BMA is really clear that as things stand, large numbers of practices are still on the brink financially. So obviously those contract uplifts I mentioned are in England, but the pressure on general practice is something that's the case across the UK. And we know in Scotland that GPs are moving closer to industrial action over underfunding. In Northern Ireland, practice closures are happening. And Dr. Bramall-Stainer talked about a 38% rise in patients per GP in Wales over the past decade. So that pressure is very much a UK-wide issue. And this document highlights why GPs are so valuable. More GPs and the improvement in continuity of care that comes with that means lower mortality. It means reduced pressure on out of hours and emergency services, fewer hospital attendances and admissions, reduction in prescribing, and ultimately a rise in life expectancy. And this report basically sets out the evidence for all of those points. It compares GPs delivering continuity of care to the closest thing the government has to a silver bullet in healthcare terms. And basically the message is, there are lots of GPs available, struggling to find work right now. Give general practice the funding to bring those doctors into the workforce and the country will reap the benefits.
GP unemployment was a huge issue at that event last week. It's basically not something that's gone away. And I think we've spoken on the podcast before about the fact that this is a problem that's spreading from England to other parts of the UK. Scotland in particular is starting to see some real problems around GP unemployment, all because underfunding means practices just cannot afford to hire GPs. And the other side of that unemployment means that the GPs who are in the practice are having to work harder than ever because there's no money to get more GPs in or to get locum cover in when people are off. So it affects all parts of the profession in the end, even those GPs who have a job. There was a themed debate on this issue at the UK LMCs conference last week. And one thing that really struck me from that was that lots of delegates stood up and said, we can't wait for a new contract to sort this out. Something needs to be done now, and it needs to be done as soon as possible to address the problem. Just ahead of the debate, the BMA Sessional GP Committee Chair in England, Dr. Mark Steggles, shared some anonymous testimonies that the BMA had received as part of a survey it carried out into this issue earlier this year. And those stories were quite harrowing. One GP planning to go and work in Canada and leaving his wife and children behind because he can't find work and he was going to send money back. People really worried about the lack of work, worried they can't pay their bills or their mortgage, not sleeping, anxiety, and people feeling forced into choosing another job because of all of this. I mean, what a waste for the NHS, for patients. And it's not as if the work isn't there for GPs to do, is it? Someone in that debate also said they were really worried that this situation was starting to become the norm now because it's gone on for so long. And just generally, a lot of anger that has come to this, and anger with politicians about them not seeming willing to be able to actually properly deal with this problem. And I think the other thing is important to mention is it's not just unemployment, it's underemployment as well. So lots and lots of GPs just can't get the amount of work that they need or they want. So we've come to a point now we can't really say we don't have enough GPs anymore. We do. There's a huge untapped capacity there, particularly among locum GPs who were working a lot of sessions before this unemployment issue started arising. And now many of those are scrabbling around to find any bits and bobs of work they can. There's lots of GPs out there who want to work more sessions and can't because the funding is just not there for practices to employ them to do it.
That's a massive issue. But one of the other things that came up, I guess, feeds into the same element of underfunding for practices, problems with funding. There was a big debate about the impact of employer national insurance contributions, wasn't there? So what came up in that?
This is another really major issue, and it's another issue that's just not gone away either. We've not talked about it for a while on the podcast, but it is a big concern for practices. And this debate at the UK LMCs conference really showed this. So as you've touched on, Nick, while we've been talking, we have a deal for this financial year for the GP contract in England. There's fairly warm words from the BMA about the government moving in the right direction on general practice in this country. But that isn't the case in Scotland, Wales and Northern Ireland. GPs in Northern Ireland have been voting in a referendum on their contract offer for 2025-26. And this week, the results showed a massive 99%. Well, it was actually 99.6% of GPs in Northern Ireland rejected that deal. The BMA GP committee in Northern Ireland has said GPs are prepared to take collective action if the government there does not come back with an improved offer. Funding for national insurance contribution rises was a key ask for GPs in Northern Ireland. The BMA says the deal that was on the table went nowhere near far enough to help cover those extra costs. GPs in Scotland have recently launched a campaign urging the government to find £290 million to restore GP funding, warning that the current direction of travel is driving the profession towards formal industrial action. Welsh GPs got an improved deal for 2024-25, but right at the end of that financial year, and only after they voted overwhelmingly to reject the offer that was on the table, and they were also heading towards industrial action. And that deal in Wales included a one-off stabilisation payment, and the BMA in Wales is now really pushing to make that recurrent, mainly in light of this employer national insurance rise. But even though GPs in England may on the face of it have a deal, there is still a lot of anger here, I think, about the national insurance rise as well. GPs at the UK LMCs conference overwhelmingly backed all parts of a motion that said the rise in national insurance contributions could become a tipping point that puts the future stability of practices at risk unless there's an urgent intervention from the government. People were talking about many practices being left with no alternative but to hand back their contracts if there wasn't steps taken to rectify this. And in particular, a lot of people very, very unhappy with that comment we talked about last year from Wes Streeting about general practice not being formally part of the NHS, which means practices are not eligible for any exemption on this national insurance contributions rise. That's really upset people, and they've not forgotten it. So while on the face of it, this year's GP contract in England is much better than in previous years and is generally being viewed quite positively, the increase in employer national insurance contributions has really undermined that a lot, I think.
Was there anything else that came up from the conference that we should talk about?
One thing I think is worth mentioning is that delegates also backed a motion saying that we need to define what core general practice is and calling on the BMA to set up a working group to do this. So basically, practices provide what we know as core GP services, but it's not really defined exactly what core GP services are. And the argument now is that unless you define exactly what GPs are expected to provide under the GP contract. It makes it really difficult to push back against unfunded work. So work, for example, that hospitals say GPs should be doing. And this is why we have this situation, where GP practices in some parts of the country might be funded for providing a particular service, while practices elsewhere are providing it for free. There's some real concern that as the government tries to move more services out of hospital and into the community, practices could come under increasing pressure to take on work without proper remuneration. So defining core services could be a way to protect practices from that. The argument is that if commissioners are clear what practices should be doing, what community providers should be doing, what hospitals should be doing, and then if there's a gap somewhere, then they need to commission something and pay someone appropriately for filling that gap. And obviously, if it's clear what practices should be doing, then it's clear what they shouldn't be doing and when they can push back against inappropriate workload dump and demand payment for extra work. There has been an argument against defining core services. That it's basically quite difficult to define what general practice does, that really captures that idea of providing holistic care, and that maybe a hard and fast definition of what general practice should be doing could prevent practices from adapting and being more flexible and innovative to meet patient needs. But I think the funding crisis we're seeing in general practice now, the huge workloads practices are dealing with, and also the amount of expectation from other parts of the system that general practice will just pick up the pieces when everyone else stops. I think all of those things are really starting to sweep away those arguments against defining core services. So I don't think it was a surprise that delegates voted for this, but I think it's going to be really interesting to see how the BMA approaches actually doing this, how the profession is consulted and what the final result of all that is. And then obviously also how UK governments react to that and whether they are prepared to build in a definition of core services into future GP contracts. I mean, obviously that's a big question mark over whether governments would go for that or not in the end of all of this. Moving on, ICBs have until the end of this month to set out how they intend to cut their running costs by 50%. The government mandate to significantly scale back ICBs, which was announced in March, came in the wake of its decision to scrap NHS England and merge many of that organisation's functions into the Department of Health and Social Care. Last week, NHS England issued a blueprint to ICBs setting out a vision of what they should look like in the future, which they are supposed to use to develop the plans they need to submit at the end of the month. Nick, as a bit of a top line, what does this blueprint actually say?
Back in March, the government announced plans to abolish NHS England and start merging its functions back into the Department of Health. And as part of this, the government wants to cut running costs at the centre of the NHS by half, and it's ordered ICBs to do the same. Cuts on that scale clearly mean big changes, lots of redundancies and so on. And this blueprint is an attempt to give some guidance about how some of the changes ICBs will need to make could look. It's been drawn up by a select group of ICB leaders from across the country, and it sketches out what they see as the core role and functions of ICBs. And it gives some guidance on the types of things ICBs should let other bits of the health service system take on and what they should probably keep and continue to do. Just stepping back for a bit, the blueprint is very much rooted in Lord Aradasi's rapid review of the NHS last year. That highlighted duplication of functions and ambiguity in the relationships between ICBs and provider organisations, as well as some variation in how ICBs interpret what they're expected to do, so what's expected of them. And it called for a more standardised approach. And in broad terms, the vision is for ICBs to become more strategy focused. And to achieve that, along with the cost reductions that the government wants, they're planning to get providers to take on some of the work ICBs currently do. For primary care, that could mean providers, and we're probably talking about neighbourhood teams in some form, taking on more control of things like NHS estates, GP IT systems, and primary care transformation work. So some bits of ICB work, potentially including performance management of providers, so again, something that could affect GPs, could shift in the other direction, sort of up the NHS chain and be run at regional level. So that's a sense of what's in this document, but it actually admits in the introduction that it's difficult to be clear about how things will actually shape up because there's still no clear picture of what the government's plan for neighbourhood health is, or what other organisations are going to look like within the general NHS architecture. So some of this could well shift again when the government publishes its 10-year plan for the NHS sometime soon.
It is all a bit unclear, isn't it? I was talking to someone who works in an ICB the other day about this, and they were saying that no one seems very clear about what this all means and exactly what functions they should be hiving off, and if so, where they should be going. I think the blueprint is basically, suitably vague so that ICBs can apply it to their own situations. And we know things are very different in different parts of the country, but that's not necessarily that helpful, is it? The other thing that's interesting, it talks about moving some of these functions to neighbourhood health providers. I mean, who exactly are these neighbourhood health providers? Does NHS England mean existing organisations? Could that be GP federations if they're already providing services? Does it mean hospital trusts if they're providing some services in the community? Is it local authorities? Or are they talking about something new? And if so, what's that? One of the other things that really struck me, the first time I've really heard this term neighbourhood health providers has been in these communications that have been sent out to ICBs about these cuts they need to make. This one that's come out in the last couple of weeks, and that first one a month or so ago, is not really a well-used phrase or term in the NHS, is it, at the minute? But I think it's clear it's going to be. Some of the functions you were talking about there, Nick, that the government is expecting ICBs to move to providers, they are kind of statutory functions, so they'll have to be carried out by real concrete organisations that are set up properly. They're not things that could be done by the current iteration of most integrated neighbourhood teams, for example. In most places, integrated neighbourhood teams are not proper organisations. They're a collaboration of many different providers and organisations, so they can't hold budgets, they can't employ people. But maybe that's where this is all heading, towards neighbourhood teams becoming provider organisations that then have responsibilities like all of these extra things like medicine management, potentially estates. And I suppose that, there's some other questions that ICBs are going to have to be grappling with. And I'm sure ICB staff will be wondering about, if the ICB does hive off some of these functions to any of these providers, does that mean that ICB staff will be able to move to these organisations, or will these organisations just be expected to take on these extra responsibilities?
On that front, what's interesting is that the blueprint talks very clearly about the fact that shuffling the deck chairs around, that kind of thing, this role might move from this organisation to another. That's not going to be enough because the scale of cuts that they're envisaging are just way beyond that. So they're talking about merging functions. So this is about ICBs, no longer each having an individual person doing some of these roles that they currently do. They've been set a target of just under £19 per patient as a sort of running cost total. I was reading through the board papers of one ICB recently, which was saying that currently it's around about the £33 mark. That ICB, as it happens, is going to have to reduce its running cost by a bit less than the 50% national target. But that, it shows you that some people are well in excess of £33 currently. And if you're talking about that, then the money simply won't be in the system to keep all the people who are currently employed in their jobs.
Yeah, exactly. Just from everything we've talked about today, I think this is just a really big ask of ICBs to get these plans together by the end of the month, particularly when staff in those organisations are facing losing their job and potentially, pretty demoralised. And it sounds like, what they put together as part of these plans, which are going to be quite difficult for them to do, it sounds like some of that stuff might even need to be changed and adapted when the 10-year plan comes out. As you said, that blueprint actually says that it's coming ahead of the 10-year plan and that the 10-year plan is going to set out more detail on the wider system and clarify roles and responsibilities. But we know that that's not coming until June. So potentially lots of things that might need to change again after they've even made those plans at the end of this month. But I think what's becoming increasingly apparent from all of this is that neighbourhoods is really clearly the direction of travel, and a much bigger role for neighbourhoods, whatever they might look like, much reduced role for ICBs. And I suppose the big thing we've really got to hope is that this 10-year health plan will really explain exactly what neighbourhoods are and where general practice will fit in them and how they are likely to interact with each other.
Well, and then beyond that the role for general practice that the 10-year plan sketches out is something that GPs are happy with.
There's a lot riding on what's going to be in that plan in terms of how all of this is going to affect general practice. Before we go, we've just got time for our good news story, which this week is about a pilot in general practice in Manchester that is aiming to cut falls among older patients. The pilot is making use of a new digital system called eFalls, which helps GPs identify older patients at moderate risk of falling in the future so that they can receive early support to help prevent injuries and maintain their independence. The system was developed by researchers at the universities of Leeds and Birmingham, and this is the first time it's been used in the real world. It's being piloted by South Wigan Ashton North Primary Care Network, which covers around 37,000 people. The eFalls tool searches within GP practice clinical systems to put patients in different risk categories. During the pilot phase, these searches will be run by NHS Greater Manchester's data team, but the longer-term aim is for the tool to be embedded in GP IT systems to enable practices to run the searches themselves. Patients identified at risk are then offered a place on the Falls Management Exercise Programme and may also be referred for site checks and other support. The pilot has been supported with funding from the Office for Health Improvement and Disparities and the Centre for Ageing Better. It started in February this year and will run for 9 months. Well, that's it for this week. Thanks to Nick and thanks so much for listening. I'll be back next week when I'm talking to GP Dr. Caroline Watson, who's the chair of the Royal College of GPs Secure Environments Group, about the challenges and rewards of working as a GP in a prison or another secure environment. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.